who is a third-year student in our Health and Clinical Informatics PhD program. Frances has a bachelor's degree in biochemistry and cell biology, as well as a master's degree in bioscience and health policy from Rice University in Houston. She has participated in a wide range of research from wet bench to clinical trials, health policy, and most recently worked on systematic reviews at the Pacific Northwest EPC. She has always been drawn to cancer research, particularly the precision medicine and predictive analytic initiatives. Her interest led her to clinical informatics, and she hopes that her research will contribute to responsible use of EHR data for research.
Thank you, Nicole. Hi, everyone. Thank you for attending today. Today we'll be talking about applying causal inference to real-world data. Just a brief outline of today's presentation. First, I'll go over the motivation coming from the recent trends in healthcare and gaps when we do use EHR data for research, and then an opportunity of applying causal inference to when using EHR data for research, and lastly, present a use case of a pancreatic ductal adenocarcinoma to investigate whether or not we could use causal inference for EHR research. I'm sure that we are all aware of the widespread EHR adoption in the US, where about 80% of office-based physicians and 90% of hospitals have adopted some form of EHR. Although EHR was not initially designed for research purposes, researchers are excited to use this readily available vast amount of data for research when traditional data generation and collections are time-consuming and expensive. And there's a national shift from considering EHR data for research as a secondary use to a primary use in a learning health system. This concept was originally proposed by the National Academy of Medicine and now promoted by the Agency for Healthcare Research and Quality, or AHRQ. In a learning health system, data generated during healthcare practice, such as EHR and administrative data, are used for research to generate evidence that will inform future clinical practice in a continuous feedback loop. The learning health system can help us achieve the quadruple aim of healthcare, which are to improve patient experience, improve population health, improve clinician well-being, and reduce cost. Since the HITECH Act, there is a steady increase in number of publications using EHR data. This graph is from a bibliometric study by Javali et al., and their research was executed on November 2021. So the actual number of publications, citations, and cited publications are likely to be even higher for 2021. At the same time, the number of machine learning publications has grown even faster within the last 5 years. Many machine learning research uses EHR data, such as Forest Clinical Decision Support System. While this follows the learning health system model, we should be cautious as bad data or poor model specification could lead to poor prediction, such as EPIC's sepsis algorithm and some other examples that I will go into. So despite the rise in popularity of using EHR data for research, many authors appropriately caution that observational data can only infer association, not causation. Furthermore, unmeasured or omitted variables can contribute to confounding bias. For these and other reasons, suspicion in machine learning and artificial intelligence remains. Like observational studies, machine learning algorithms identify variables associated with the outcome, not necessarily those in the causal pathway. So let's talk about the difference between randomized controlled trials, or RCTs, and observational study. Randomization minimizes confounding and other types of biases, providing excellent internal validity, which means that we are confident in the causal relationship being tested in an experiment and that the result is not likely to be influenced by other factors. However, they typically have a short duration lasting up to 1 to 2 years, so long-term efficacy is unknown, or there's a high attrition and the finding is not as robust. For conditions where most important endpoint is many years down the road from treatment, such as cancer survival, clinical trials often use surrogate endpoints that can be measured within 1 to 2 years, such as disease-free survival. But sometimes these surrogate endpoints have not been validated to truly reflect a benefit in survival or quality of life. Because of their high cost, they usually have relatively small sample size in the hundreds, which means they cannot conduct subgroup analysis. RCTs are often criticized for lack of external validity, or limited generalizability. It is estimated that less than 10% of cancer patients qualify for a clinical trials. Lastly, RCTs may not be feasible due to ethical reasons or small patient population to actually recruit for an RCT. On the other hand, these limitations of RCTs are advantages of observational studies. Observational data typically contain thousands to tens of thousands of patients, allowing for subgroup analysis. They also better reflect real-world setting and how well the treatment actually work in the real world. Some observational data have long follow-up. Lastly, the large population means it is more suitable for rare adverse events, where you need a large population to observe these rare events. However, observational data is susceptible to biases. Some databases, especially when not set up in a prospective data collection, may not contain all of the details that the researchers would like, such as performance status or comorbidity. In general, observational studies agree with RCTs. As you can see in these two figures, the top dot and confidence interval represent the pooled estimate of observational studies, while the bottom point represents pooled estimate from RCTs. The figure on the left represent cardiologic treatments, and the figure on the right are non-cardiologic treatments. Most of the pair occur on the same site, reaching similar conclusion, although there are a few where they diverge, such as here, where RCTs have no findings. But your observational study suggests one treatment is better than the other, and another example here. So there are a few notable examples when RCTs and observational studies reached conflicting conclusions that could lead to patient harms. In the 80s and 90s, physicians noticed that perimenopausal women on hormone replacement therapy showed lower rates of coronary heart disease, as seen in these two forest plots. This prompted the Women's Health Initiative to initiate a randomized controlled trial investigating HRT's effect on a variety of diseases. But the trial was terminated early because of interim analysis showing that HRT actually increased the rate of coronary heart disease, VTE, and invasive breast cancer. More recently, two meta-analyses found that about 2/3 of observational studies do not agree with their respective RCTs. Using observational studies based on national registries, Soliano found no significant correlation between clinical trials and observational studies, and only 62% of observational studies hazard ratio falls within the 95% confidence interval of randomized trials. Meanwhile, Kumar et al. Used the National Cancer Database to replicate clinical trials mentioned by the National Comprehensive Cancer Network clinical practice guidelines for 8 common solid tumors. For each comparison, they tested 3 models: a simple univariate, an adjusted multivariable, and a propensity score adjusted model. For a primary outcome of concordance, only 70% of multivariable models and 64% of propensity score adjusted models hazard ratio falls within the 95% confidence interval reported by RCT. Using a more crude assessment of p-value, only 61% of multivariable NCDB analysis correctly favor the same arm as the clinical trial, and similarly, only 61% from propensity score adjusted model finds the same conclusion. And interestingly, you have some that actually favor the opposite arm as from the clinical trial. On the other hand, when clinical trials finds no difference between treatment arms, about 2/3 of the multivariable and propensity score adjusted model actually found a difference between treatment arms. Some may suggest that because of the larger population in observational database, they are more likely to find small difference. However, Sony et al. Investigated and found that only 12% of studies that disagree between observational studies and RCTs fall between 0.9 and 1.1, suggesting a really small difference detected by a large population. Therefore, the larger patient population in observational data does not fully account for the difference between RCTs and observational studies on cancer treatments. Now, many smart people have written about potential reasons for this discrepancy observed between RCTs and observational studies. Some are nicely summarized in this table on the left by Franklin et al. First, patient population may not be accurately captured in real-world data, so the underlying sample are different between the two study designs. Second, treatment are usually tightly controlled with frequent follow-ups to ensure that patients are following the protocol. In reality, patients are typically less compliant with treatment. And lastly, there could be difference in outcome measurement that could be affected by amount of missingness and length of follow-up. Additional potential reasons include unadjusted confounding, bias in observational studies, publication bias where null findings are less likely to be published, and selection bias. Now, I've talked about bias several times, so let's really discuss what exactly is bias. Bias is a systematic error in the design, conduct, or analysis of a study that results in a mistaken estimate of an exposure's effect on the risk of outcome. Note that this is a systematic error, not random error, which can be captured by statistical methods such as confidence interval and mitigated with larger samples population. On the other hand, bias cannot be mitigated with the larger sample population because all data would be skewed in the same way. So the first type of bias is selection bias, where only selected patients are included. This form of bias can affect both RCTs and observational studies. For example, healthy younger patients are more likely to be recruited in RCTs, while the true patient population are likely to be older and have more comorbidities. On the other hand, health-conscious people are more likely to participate in a cohort study on healthy lifestyle and mortality, known as volunteer or self-selection bias. The second type of bias is information bias, which is a different measurement error on how information are collected and handled between comparison groups. This is more likely to occur in observational studies. For example, users with lower screen time tend to overestimate their screen usage, while users with higher screen time tend to underestimate their usage. So as a result, this reported information reduces the true range of screen time usage and will more likely lead to null findings. The last type of bias is confounding bias, caused by a confounder that causes both the exposure and the outcome. This factor results in a spurious association between the exposure and outcome, or mask their true relation. In our earlier example of hormone therapy in perimenopausal women, socioeconomic status and coronary artery disease risk factors are potential confounders, and adjusting for them nullify the seemingly protective effect of hormone therapy on cardiovascular disease mortality. This is an example illustrating confounding bias. In this meta-analysis comparing glucose-lowering drug GLP-1 with insulin, RCTs are shown in the top in red, while observational studies are in the bottom in blue. So most of the RCTs favors GLP-1 or null findings, and in contrast, the three blue open squares you see here are unadjusted observational studies that favor insulin. So when you adjust for confounders, they're more likely to favor GLP-1, much like the RCTs. Returning to our hormone therapy example, it appeared that confounding led to an overestimate of the benefit, and adjusting for socioeconomic status and risk factors attenuated the benefit. Furthermore, examining subgroups by age and menopause onset suggested that younger women may benefit from hormone therapy. This led to the hypothesis that estrogen may be beneficial in healthy arteries in younger women. And interestingly, in this case, it is possible that observational data's longer follow-up may have introduced bias, as women who experience adverse effects from hormone therapy are more likely to discontinue it early on. So the cohort was skewed towards healthy women who have continued on hormone therapy for a long time. Kind of opposite to confounding bias is overadjustment bias. So in this situation, a noun confounder is adjusted for, leading to a distortion of the relation between exposure and outcome. For example, in obstetrics, gestational age is often adjusted for as a confounder. However, it could be an intermediate variable or a collider, and adjusting for it would mask the true relation between the exposure and your outcome. In this example, gestational age is likely an intermediate variable between preeclampsia and cerebral palsy. In the sample graph, the solid line represents women with preeclampsia, and the dashed line represents those without preeclampsia on their risk of cerebral palsy based on gestational age. So as you can see, it appears that women with preeclampsia have a lower risk of having children with cerebral palsy, and that is a little baffling. So when you adjust for gestational age, it appears that there is a protective effect on cerebral palsy, which is not true. So what is likely true is that most of the deleterious effect of preeclampsia on cerebral palsy is mediated through the shorter gestational age. So when gestational age is controlled for, the result is only the direct effect of preeclampsia on cerebral palsy, which may be null. A more recently recognized type of bias is social bias. So in 2019, Obermeyer et al. Found a case management referral program algorithm that is less likely to refer Black patients with comparable health status as white patients. The authors suggested that this bias arises because algorithms predict healthcare costs rather than true illness. But unequal access to care means that we spend less money caring for Black patients than for white patients. Or in other words, a Black patient is likely sicker than their white counterpart to incur the same amount of healthcare cost. The study raised two important points. First, social process may imprint bias onto data, so this should be evaluated for in future. And two, variable selection is extremely important. Sometimes surrogate variables answer a different question than the one we're initially asked. There are some statistical methods that allow observational studies to better emulate RCT, such as propensity score analysis and inverse probability weighting. However, there have been some debate about the utility of propensity score matching. As we saw earlier in the cancer treatment meta-analysis, propensity score model did not perform better than multivariable model. So Guo et al. Suggested that this is partially because propensity score method heavily relies on model assumptions and knowledge of the causal mechanism to identify correct variables to adjust for and taken into calculation. Lastly, there are likely new sources of bias in EHR data in addition to biases in traditional observational data, such as registries and administrative database. For example, informative presence bias means sicker patients generate more data. Conversely, healthier patients are less likely to have healthcare encounters, so their data may be sparse or not included in large academic health centers where most research are generated. This type of differential information bias likely contributed to the discrepancy between RCTs and observational studies on cardiovascular benefits of bariatric surgery. So two observational studies using EHR data suggested a 40 to 50% reduction in major adverse cardiovascular events in patients undergoing bariatric surgery, but a small preliminary RCT did not find any benefit. So Rassen et al. Went out to investigate this discrepancy, and they compared patients with bariatric surgery to patients with hip or knee arthroplasty. And in that comparison, they did not find any cardiovascular benefits like the RCT. The authors suggested that using an active comparator group with comparable healthcare encounters nullified the cardiovascular benefits of bariatric surgery. My preliminary literature search only identified two potential good frameworks for evaluating biases in EHR data, but no systematic review. The framework on the left here by Terrace et al. Identifies where bias could occur in the healthcare process. Meanwhile, the Dutch group was funded by the European Commission to develop a core information architecture for the European learning health system, primarily based on EHR data. Their framework captures the entire data pipeline from data generation and during clinical practice to storage and database and extraction for research. These are good foundational frameworks, but do not highlight specific biases that researchers should be aware of. The lack of systematic review is problematic because there are lesser known biases in the informatics literature that have substantial consequence on analysis. We have already seen overadjustment and social bias, so now I'll mention collider bias. A collider is caused by the exposure and outcome independently, in contrast to confounder. Adjusting for a collider distorts the relation between exposure and outcome, and you could cause a spurious relation. And an in-progress review by Nicole and Chrissy found that only 3 publications in 10 informatics journals searched that contained the term collider bias, showing how less represented it is in the informatics literature. Confounding by indication occurs when an indication such as heart disease causes the outcome, such as stroke, that is also associated with the exposure, such as aspirin use. And immortal time bias refers to a time period introduced by the study design where the patients are immortal. This bias tends to exaggerate the effectiveness of drugs by creating a survival advantage for the exposed patients. So in this example, patient 2, that requires filling 2 prescriptions for aspirin in order to be classified as an aspirin user. Patient number 2 has an immortal time here between diagnosis and when they first fill their aspirin prescription. So this time is mistakenly attributed to a benefit of aspirin when the patient is not really under the treatment of aspirin. And misclassification bias is really prevalent in could be prevalent in EHR2, as you can see here. So for patients who do not have the disease but are being worked up to rule out the disease, may be mistakenly captured as having the disease. On the other hand, patients seeking care elsewhere for the disease who might actually have the disease, but that is not documented in this particular institution's EHR, will then be misclassified as not having the disease. So to quickly summarize, there are several known issues with using EHR data for clinical research. Number 1 is inappropriate adjustments, such as over-adjusting or collider bias. There are hidden social biases in data as a result of the healthcare process, and a lack of catalog of bias specific to EHR data. So to better emulate RCTs, clinical research informatics needs to identify and catalog biases in EHR data and address them appropriately. So I'm proposing that causal inference is a potential solution to better utilize EHR data for research. One of the founding fathers of this field is Judea Pearl, and he defines it as an extra statistical method that can be used to express and interpret causal assumptions. And a better definition is an intellectual discipline that considers the assumptions, study designs, and estimation strategies that allow researchers to draw causal conclusions based on data. I want to point out that in causal inference, we're interested in causation. So we're interested in this counterfactual framework of what if everyone is treated versus what if everyone is not treated. This is different from association, where we're studying what is the risk of outcome in people who are treated versus the risk of outcome in people who are not treated. A causal model represents the mechanism by which data are generated. Structural causal model is a way of describing the relevant features of the world and how they interact with each other. This is a directed acyclic graph. Directed means the arrows represent how one variable is a cause for another variable, and acyclic meaning you cannot have a cycle that goes back to this variable. And the DAG represents unstated relationships between variables. It states it explicitly, so we can inform readers the choice of which variables we are collecting. It helps us differentiate confounders from mediators, and therefore determine what variables to control for. And it explains and identifies selection bias, and it supports effective communication between researchers. Now I'll briefly go over what each one of those middle variables mean. To start, a confounder we have talked about is a common cause of treatment and outcome, but not on the causal pathway. So for example, age is a confounder in the relationship between exercise and cholesterol. If you look at this graph, you say, oh, great, more exercise increases my cholesterol level, so I should not exercise. But we're ignoring the age confounder here, where age is related. The older you are, the more likely you will exercise, but also you're more likely to have higher cholesterol level. So within each age group, exercise still reduces your cholesterol level. A mediator or intermediate variable is affected by the exposure and affects the outcome. So in our earlier example, a maternal age is likely going to affect your chance of preeclampsia, which will also then affect your chance of cerebral palsy. An effect modifier moderates the average causal effect of exposure on outcome. For example, sex, often included as a confounder, is more likely to be an effect modifier. So for example, in this drug that increases your HDL level, it is highly effective in men, but not so much in women. So depending on your study composition, this drug could appear as if there is no effect on your HDL level, when in fact it is really beneficial for men. A collider is a variable caused by both exposure and outcome. Collider bias is a spurious association between exposure and outcome when conditioning on their common effect, this collider. Selection bias is an association between exposure and outcome created as a result of the process by which individuals are selected into the analysis. Some selection bias is a form of collider bias if the selection factor is a collider. So in this example, locomotor disease and respiratory disease, the relation between them, if you condition on using an inpatient population EHR data, then you might generate the spurious relations because patients with locomotor disease are likely to be hospitalized, and at the same time, respiratory disease patients are more likely to be hospitalized. So it appears as if there is a relation between these two diseases when there is probably not. So directed acyclic graph encodes domain knowledge and assumptions to guide analysis. Traditional statistical definition of a confounder is a variable that is associated with exposure and outcome and does not lie on the causal pathway, which would indicate a mediator. However, where the arrow points help us distinguish between a confounder and a collider. So these are various ways of representing what is the potential causal mechanism between preeclampsia and cerebral palsy, and if gestational age is secondary to abruption. So there are three main assumptions when applying causal inference to observational data. These are complex concepts, but I just want to point out these assumptions are important to make observational studies more similar to RCTs. And the field recognizes that these are strong assumptions. So first is exchangeability, or the risk of outcome in group A is the same as risk of outcome in group B, had group B received the same treatment as given to group A. And positivity, the probability of receiving every value of treatment is greater than 0. In other words, everyone should have some non-zero probability of receiving the intervention. This is important particularly when using propensity score matching or inverse probability weighting, but not just for propensity scores, because to emulate an RCT, everyone can be randomized to either group in an RCT. The last assumption is consistency, or values of exposure correspond to well-defined interventions. In other words, one needs to be able to explain how a certain level of exposure could be hypothetically assigned to a person with a different exposure level. So consider, how would you assign a healthy BMI of less than 25? You can't just randomly magically make someone BMI under 25, so that is not a good exposure to study. Rather, a better exposure to study would be exercise intervention to achieve a healthier BMI or a weight loss drug. And that leads me to my research question is, how can we improve inference from EHR data when RCTs are not feasible or available? I'm hypothesizing that a causal framework using EHR data with appropriate bias adjustment will yield results closer to RCTs. And briefly, the three specific aims are: 1, to synthesize biases unique to EHR data; 2, identify PDAC treatment decision process that contributes to patient selection for either treatment pathway; and 3, to construct a causal model emulating the PREOPANC-1 trial to include bias variables from aim 1 and patient selection factors from aim 2 and internally validate the model. Briefly, just touching upon the use case of pancreatic cancer, it is ranked 10th in incidence, but 3rd in mortality in the US. At the time of diagnosis, most people are in the metastatic stage or stage 4, and that has a really poor 5-year survival, less than 3%. Pancreatic ductal adenocarcinoma, or PDAC, accounts for 85% of pancreatic cancer, so it is the most prevalent kind. And about 15 to 20% of patients with PDAC have resectable disease. There are some risk factors for PDAC, but even in people with family history of PDAC, only about 50% of them would actually have PDAC. Other risk factors include chronic pancreatitis, pancreatic cysts, tobacco smoking, obesity, and diabetes. Symptoms for PDAC are not very specific and contribute to their delayed diagnosis by at least about 2 months. Shown here are the 2 treatment pathways recommended in the clinical practice guideline by NCCN. So on the top is resectable disease, patients with the best prognosis, and the bottom is borderline resectable disease, people who can still undergo surgery. I've highlighted these 2 boxes here that recommends neoadjuvant therapy, but the true utility of neoadjuvant therapy is not really well known. So to talk about neoadjuvant therapy refers to systemic chemo or radiation therapy given before a surgery, as opposed to adjuvant therapy, which is given after the surgery. The thought is that after undergoing this massive surgical procedure, only 50% of patients can receive adjuvant therapy due to poor performance status or discovery of metastasis while the patient is recovering from their surgery. So instead, by giving them systemic therapy upfront, 100% of the patient population can receive this therapy and likely to treat micrometastases. Neoadjuvant therapy may also improve the likelihood of a negative margin resection, which is associated with improved survival. And also during neoadjuvant therapy, patients with more rapidly progressing disease can be identified and spared of a long surgery that would not likely be beneficial. So in one of my previously mentioned meta-analysis comparing RCTs and observational studies, about 2/3 of pancreatic cancer treatment pairs were concordant or consistent with each other with the RCT. And that is generally in line with about 2/3 of cancer treatments are concordant between RCTs and observational studies. As we saw earlier, the NCCN recommends considering neoadjuvant therapy prior to surgery, but true effectiveness is not clear-cut. So this is based on first some observational studies published in 2016 suggesting a benefit of neoadjuvant therapy compared to surgery first. But a separate observational studies find no benefit. And a small RCTs also find no benefit. So it appears that we're leaning towards there is no difference. And because of the relatively small population of pancreatic cancer, 2 German trials were actually terminated early due to low recruitment. Until finally in 2020, the Dutch team finished a PRIO-PANC1 trial, and they found no significant difference except maybe some benefit in more advanced borderline resectable patients. So it seems like this might be resolved until very recently in 2022, the same team came back and found there is actually a difference and neoadjuvant therapy is better than surgery first in a really long-term follow-up of almost 5 years. So if you're like me, I'm still a little not sure which side is better. If I have the disease today, I don't know whether or not I want to go with the more aggressive neoadjuvant up front, have the surgery and adjuvant therapy after, or just have the surgery first. So in conclusion, applying causal inference to model PDAC patients' EHR data could better emulate RCTs. Pancreatic cancer has a high mortality rate and incidence is rising. However, the relatively low number of patients make it difficult to recruit patients for clinical trials, so patients and clinicians rely on observational studies to inform treatment decision-making. When trial becomes available, sometimes it conflicts with previous observational studies. AHR data offers potentially more granular data than current registries such as SEER and NCDB that could supplement evidence base in the absence of trial data. Recognizing biases in EHR data allows researchers to better mitigate them. So using a causal inference tools and concept to model patient outcomes could fill in an evidence gap and generate worthy hypotheses for future RCTs. It is estimated that we have about 3,000 pancreatic cancer in the Oregon State Cancer Registry, and about 600 to 1,300 surgeries have been conducted at OHSU. So we estimate that this could be feasible with just OHSU patient data. And finally, I would just like to acknowledge the mentors shown here, and DMICE students, former and current, and DMICE other faculty and staff, and the support from the National Library of Medicine. And I'll be happy to take any questions.
Are you able to see questions if they come in on that?
Can try.
You might need to stop sharing.
Yeah. I like that.
Hi, Francis. Can you hear me?
Hi, is this Adib?
Yeah. I have a quick question, and we discussed this earlier, I think. But one of the major limitations of this causal inference approach is the unobserved confounders. And if you're trying to model that, like how are you going to handle that in EHR data?
I'm sorry, I didn't hear the first half. Model confounders.
Unobserved confounders.
Unobserved confounders. Yes, that is a really great question. And my previous answer was to look at surrogate variables, which I know I've just mentioned that surrogate variables are not great. I put up a slide. There's one potential method of using an e-value to see how much does an unmeasured confounder affect your relations, and how great is this confounder's influence to change your conclusion. And I think it's a useful tool, but there's some debate to whether or not it is useful. So I think I would still like to include this e-value to account for what is the potentially one single unmeasured confounder's influence on the result.
Sounds good. Thank you, Francis.
Thank you.
Question.
Mm.
So if you mentioned cases where the observational study may contradict the clinical trial, does looking at the effect size ever help you kind of decide which one you should place more weight on?
Oh, interesting question. So I think clinicians more likely are going to trust the trial data. And personally, I would say a meta-analysis of all of your RCTs and combine it with your observational data, then might be most useful to see where get you closer to the truth. So one trial is not definitive.
Hi, this is Karen. I have a question for you. And maybe there's some clinical expertise here that can answer this. How much choice do patients have in this process? I mean, does your clinician or your surgeon dictate this, or do you have is there a choice? Does a patient have a choice in some of this? And I don't know if we have a clinician on who could help with that.
Is Emerson going to help us with that?
Yeah, this is Emerson Chen. I'm a GI oncologist. I think occasionally there's some patients that might have some preferences, and it kind of comes out in some of the discussion and decision. But I feel like usually it's definitely more provider dictated, surgeon or from the medical oncologist. And that actually goes to my next question, Francis, are you more interested in whether we should be giving neoadjuvant chemotherapy based on some of the retrospective studies that happened, or some of the early trials done, or are you more interested in understanding factors that determine whether someone should get neoadjuvant therapy? Maybe based on patient, based on provider thinking, other risk factors. What do you think is either interesting or more feasible in looking at the EHR?
Thank you. That is a hard question. And these two sound similar, but I get it that they are ultimately different. So one is understanding, is neoadjuvant better than adjuvant, or just comparing which one is better versus what kind of patients would benefit from neoadjuvant therapy. I think what I'm proposing first is to study the first question, is just to really try to model how does EHR data compare to RCTs when we are trying to answer the same questions. And the patient factors, why I'm interested in that is because they could potentially be confounders, or they should be included in your inverse probability weighting to see how patients sort into either treatment pathways. Does that answer your question?
Yeah, that's. Yeah, they're two very different not very different, but different projects that just probably would approaches. Even though the Prio-Peng trial is kind of what is available that we can always compare to, and lots of updates. There is a different clinical trial that is currently ongoing that specifically tests one arm getting neoadjuvant and the other arm getting same chemo afterwards. But that study won't be completed probably for another few years. But that certainly will be something in the future that one can see, are some of the observational studies correct, or is it, or is the or does the randomized trials say something else in the future?
Mm-hmm.
I have a question about your first aim, if I could jump in there. This is Eric. First of all, great job. I think you did an excellent job covering some kind of complex causal inference, models and terminology and different types of biases in a short time. I think that was great. But I was just curious about, so your first aim you list as synthesizing biases unique to EHR data, and I know you're gonna kind of explore this through this case study here, but I was just wondering if you could talk a little bit more about kind of your goal for that aim and the process you'll take to do it, because I think, as you alluded to here, there could be great value in having like a larger application of being able to understand just biases that are inherent to EHR data in the field, and that can be applied to other cases. And so I was curious about how you kind of plan to approach that first one. Is it specific to this research question? Is it from a larger perspective? And what's your process going to be for thinking about that?
Mm-hmm. Yeah, so the first aim will not be specific to just this use case. I'm envisioning it as a more comprehensive search, so it will be following a more traditional systematic review protocol where I set up my PICO and have dual reviewers. And the question to cast is, for all studies on EHR data, what have people identified as biases in the EHR data? And compare that to biases that we have known from other observational data sources. So this would be like I'm hoping for it to be a more comprehensive capture of data of biases.
Okay, great, cool. Yeah, I think that would be, very useful for sure. and I'm happy to talk with you about it as you embark on that road.
And are there any other questions? And if not, just if the folks who are part of Francis's symposium committee could stick around for a little bit afterwards.
Nice work, Francis.
Thank you.
Lots of hand clapping. I don't know if you can see it there, but there's lots of hand clapping going on.
And Karen, do you have a few minutes to stick around as well?
I can.
Great. Thank you.